Hello, everybody, and welcome to Unit 3, Psychological Disorders, which is kind of an odd-sounding sentence to say. I'm going to tell you right up front that psychiatric disorders are not something that you're going to run into a lot in geriatrics. That's a pretty small subset within the geriatric community. I want to go through this so we can discuss them, what the effect is in the geriatric community, and because there is one, it does exist, and to separate them from dementia, which has a huge bearing in the geriatric community, and especially with nutrition. I think it's important to be able to know what they are and be able to divide them out. Okay, so you may have heard this before. Psychology is chemistry. Pretty much every psychological disorder relates to biological dysfunction, and within that biological dysfunction is either an inability to produce a neurochemical of some sort or an inability to use it correctly, absorption rates, take up, something like that. So neurological chemicals are the basis of psychiatric disorders. And side note, I will be flipping through psychiatric disorder, psychological disorder, and mental illness or disorder throughout this. They're all the same thing. The words are all the same. It may depend on who you're talking to, what words you want to use with a patient, but as far as it goes from for our point of view, all of these they're all the same thing. Geriatric patients with mental disorders are at increased risk of malnutrition. Both disease state and treatment can affect mood. So, along with all the other risks we have already for malnutrition in geriatrics, we have a mental disorder by itself in a geriatric patient increases the risk of malnutrition. Also remember that quality of life and your perception of your life and your health are independent risk factors. So we have already the risks. We have them being having a psychiatric disorder is a risk. Their opinion of their health, which is not as good if you know you have a psychiatric disorder, and your quality of life may not be as good. So they just keep piling up. Both disease state and treatment can affect mood. So either way, so it could be that having a disorder can affect your outlook on life, or knowing that you have to be treated for one can affect your outlook on life. And the final note here is that the trend in geriatric patients is toward cachexia. You often find that you'll either have patients that will gain weight while they're being treated, or they'll lose weight while being treated. And unfortunately, geriatric patients tend towards cachexia. So we're going to discuss kind of the big branches, I guess you could call it, of them. This is by no means a exhaustive study of different psychological disorders. I mean, there are people with degrees specifically in that. If that's something that you'd like to know more about, don't talk to a dietitian, talk to one of them. So the first branch we're going to discuss is anxiety. Anxiety is defined as ironically defined as an indefinable feeling of fear, dread, or danger. Examples of this are PTSD, general anxiety disorder, obsessive compulsive disorder, and phobias. It's not very common in elderly patients in and of itself. About 4% of the population has an anxiety disorder. Now, the comorbidity with depression is very high. So if you have a geriatric patient with depression, about 1/3 of those people will also present with with an anxiety disorder, usually generalized anxiety disorder, but it could be other ones. Mood disorders are exactly what they sound like. A lot of these are exactly what they sound like, honestly. It's a persistent, any kind of disorder that alters your mood is a mood disorder. These are persistent feelings of being sad, being overly happy, having fluctuations in your moods that really don't reflect what's going on around you. or a lack of mood. Remember when I said that depression in medicine can mean a just flattening of the curve, as it were, of emotion. That is also a mood disorder. The examples are depression, bipolar disorder. This is maybe the only good news you're going to get, or the geriatric population will get in this class. Less prevalent in the geriatric population than it is in the general population. It's about 1% of geriatrics versus 4.5% in a group. And then we go downhill. There's a positive correlation between depression and debility, both ways. People with debility have a tendency toward depression. People who are depressed have a tendency to also have some debility issues. Kind of get used to this train here. Mechanism is unknown exactly. You could see why someone would be depressed if they had some debility issues. Now, the other bad news in this is that this appears to be on the rise in what they call the oldest old. And you'll see this if you read through geriatric literature. You'll see the oldest old. It's not well defined. It's generally applied to people who are 80 to 85 or more. Listen, there's no dictionary textbook definition for that, but that's roughly it. If you think like more than 80 or maybe more than 85. So the depression risk, it used to look like depression risks peaked, let's go that way for you, at 40 and then dropped back down. And now we're seeing it rise in older patients. I'm not sure why. This is troublesome for a couple of reasons. We already discussed reasons why, having a mood disorder or any of these disorders can increase your risk of malnutrition. Also, depression, mood disorders seem to act as, they call them, a gateway mental disorder. This is the most common one, but when you develop, it's like a heart condition. When you develop heart disease, that puts you at risk to develop more heart disease. If you develop a mood disorder or any kind of psychological disorder, that puts you at risk to develop more psychological disorders. Not many people present with just one issue. So having someone that has depression makes them more at risk for other issues as well. Okay, now remember psychosis from the previous one. So we have the psychotic branch. This is a distorted awareness or altered perception of reality. Examples of this are schizoaffective disorder, which most people call schizophrenia, paraphrenia, which is a paranoid disorder, or Capgras delusion, which this sounds like it's just delightful disorder in which the patient believes that a loved one is not the same person. They've been replaced by a doppelganger and that their actual loved one's missing somewhere. Interestingly, signs and symptoms of psychotic disorders vary by culture. In Western cultures, you often see people that, we'll take schizophrenia. People with schizophrenia often present with auditory hallucinations. And they're terrible. They're terrible hallucinations. They have voices that are telling them, and strictly speaking, I should correct that. They don't have voices in their head. They have things talking to them. And they're telling them terrible things. They're telling them the voices are abusive, they're derogatory, they're telling them to do things that they don't want to do. Sounds miserable, absolutely miserable. Now, interestingly, in the specific study I read, they were comparing the Hindi culture in India. In that culture, people that have schizoaffective disorder, the voices are extremely positive. They're very go-get-em, they're positive, they have great things to say about you, and kind of going back to what we said before about what makes a psychological disorder, is that really affecting somebody's life? In a way that makes it detrimental to them. Is it affecting their life? Probably. Is it detrimental? Probably not. I'm not sure I'd want to get rid of a happy voice in my head or things telling me, if my bookcase said good morning to me every day and was cheerful about it, I'm not sure that it would bother me, So, eating disorders. Now, y'all are dietetics people. I know, one, that you already know what eating disorders are, and that, two, Everybody's fascinated by them. But for thoroughness' sake, eating disorders are extreme emotions, attitudes, and behaviors related to food and weight. Specifically, it ties worthiness to skinniness. Examples of this are anorexia nervosa, bulimia, and binge eating disorder. Anorexia nervosa is far and away the most common type. About 80% of patients have anorexia nervosa. Now, side note from before, I'm going to mention it again. Anorexia, the term anorexia means lack of appetite or not wanting to eat. And remember, you can have anorexia of aging, anorexia of disease, and we have anorexia nervosa. So anorexia is just not wanting to eat. Anorexia nervosa is a medical, psychological condition. Okay? I just want to bring that up again. I know that's because we're used to anorexia nervosa in general parlance, it gets confusing. So keep that in mind. Anorexia itself means just no interest in eating. We tend to associate anorexia nervosa with young women, but that is more of a cultural conceit, because this idea that women should be concerned about their appearance and their weight. Modern psychology recognizes that men suffer from eating disorders as well, not to the same degree as women, but they do, and that geriatric patients suffer from eating disorders. Again, not in the same amounts. It is still higher in women, in young women, but it does exist. Also, eating disorders have an exceptionally high recidivism rate, which means that once you treat somebody with the eating disorder, it's entirely possible that they will fall back into old habits. It's very hard to shake that cycle. And unfortunately, about 20% of people that develop an eating disorder will die from that eating disorder. The other scary thing for us as people that are geriatricians here is that geriatric patients experience greater amounts of weight loss, so they can do more damage to themselves more quickly than somebody else. Addiction and impulse control. This one gets a little tricky, so ride with me for a second here. It's very hard for people to separate the moral component of this that some people see to the disease state. Also, this one is one that you will not see very much in the elderly. I don't know if this is specifically because of the conditions that they live in, where they have less mobility and independence than they used to. Maybe they're in a facility, it makes it more difficult to get involved in these activities. Although now with modern technology, we have the wonders of being able to bring shopping and gambling to your computer. So, what an age we live in. Sorry, rabbit track. Addiction and impulse control is the excessive desire to participate in a particular habit or activity, or an inability to regulate one's behavior during the activity. Some examples of this are sex, shopping, gambling, substance abuse. And it's important to note here that while there are chemical issues involved in a drug or alcohol dependence, for example, you cannot just cut somebody off from alcohol if they have been alcoholic for a long time. That will do them permanent damage. It might kill them. And there's no real negative effects except for psychological discomfort in cutting somebody off from gambling, for example. Now, and it's also important to note from that the disorder is the inability to control oneself, right? There's no difference from a psychological point of view between sex addiction and drug addiction. And let's not take drug addiction. Let's say alcoholism. Many adults are, I don't know why I'm saying adults, like I'm clarifying, this is college, you guys are adults, can have a drink with friends after work, at dinner or something like that, and then be fine. They don't have to drink all the time. If you told them no more for you, they wouldn't care. Many adults are in healthy, happy sexual relationships that they find very fulfilling. And both of those are, fine. So it's not the issue, it's not what you're doing, it is that they are unable to control themselves in that moment or from doing that thing. That's actually the disorder. Okay, personality is the extreme or inflexible personality trait that are distressing to a person and or interfere with the person's ability to function effectively. This presents in antisocial personality disorder, which is either shortened to APD or ASPD. I've seen both. Histrionic personality disorder, which is a pathological need for attention, and narcissism, which is narcissism. I'm not 100% sure on this one that this fits the same definition of psychological disorder, simply because, for example, like antisocial personality disorder is a lack of ability to identify with other people's emotions. That people lack sympathy and empathy, which makes it easier for them to do things that we would consider terrible. It also makes it, though, so I'm not sure that they are suffering from it, if you understand what I mean. Also, it makes it easy for them to do well in the business world, when being ruthless can be a real asset. If you are thinking about closing a company that's maybe not doing well, instead of trying to buoy it up and get it to be a better performer, and instead of thinking of all of these people you're going to put out of work and their families and what are they going to do, you're like, get rid of them. That makes you a successful business person. It makes you not a really good human being, I would argue, but someone with APD doesn't feel that. So again, I'm not sure that they are suffering from an inability to function in society so much as the rest of us are uncomfortable around them. But again, that's just me in a bit of a rabbit track again, so sorry. Okay, so pharmacotherapy. All psychological medical intervention has the potential to alter PO intake habits, either by diminishing appetite, increasing appetite. Some drugs make people crave things. Just an example, side note here, Lexapro has a tendency to make people crave carbohydrates more. So any kind of drug that alters mind function can alter eating function. There are two medicines that specifically address appetite. Megace or Magestrol is one. It was specifically created to be an appetite stimulant. It was originally given to HIV or cancer patients. That's who it was designed for, people who suffered from very bad cachexia. And you will sometimes see this in geriatric care for people who are just really not eating. It's not given very often or very long, because it has some pretty heavy side effects. It has an increased risk of pulmonary thrombosis and adrenal insufficiency, so it's really not one that people like to call on. But sometimes desperate times, right? The other one is Remeron or mirtazapine, which is an antidepressant. It's an antidepressant that has a handy-dandy side effect of increasing appetite in most people. Now, this is used in two ways. One is it's used in people that just do not have an appetite. They've lost their appetite for whatever reason. Sometimes they'll be given Remeron for that. Also, it works extremely well for people who are suffering from psychological disorders that cause them to not want to eat, whether that's depression or anxiety or what have you. What I've been told by doctors and nurse practitioners in the past is that mirtazapine does not do very well on its own. It's not a very good first-line antidepressant. No shade against Remeron there, right? But what I've been told is it's a fantastic bolt-on. Excuse me. So if you'll often see somebody with on some Zoloft or Cymbalta and Remeron, but very rarely just Remeron by itself, unless they're trying to increase somebody's appetite. And a couple of tips for dealing with people with psychiatric disorders. One thing that Hollywood has often presented is that people that have psychological disorders don't know that they have psychological disorders. That is completely false. Well, mostly false. I shouldn't say completely false. Most people that have something, that have a mental illness, are aware at the very least that something is wrong. They may not be able to put their finger on it. They may not be able to explain it to you, but they know something is not right. Whether that is that somebody knows that their emotions aren't in tune with what's going on, or we'll borrow the schizophrenia patient. The schizophrenia patient understands that inanimate objects don't talk. They've been around. They get it. So they know something is wrong. The other thing that you will sometimes see depicted is that they're resistant to care. They don't want care. If you have a psychological disorder, and remember, that means that it is interfering with your life in a negative manner, most people want help. In mental institutions, the majority of people are there voluntarily. They've come to that place and like, please help me. I don't know what to do. So that's part one. Another thing to bear in mind is telling a patient it's in your head or it's not real is not helpful. Now, we did talk earlier about refocusing, facing head on their incorrect belief. But it's important to state that if you're going to do that, you need to address the belief. We'll say someone says the food is poisoned or there are monsters on the ceiling. Don't tell them you're imagining it, it's in your head. That puts them on the defensive. That makes them feel attacked. What you say is, no, remember, we've discussed this. Your food is not poisoned. You could say, I watched the kitchen make it. I was there when they did some of this. I have taken a bite of somebody's food with a clean, separate fork for them to show them that it's safe. So you want to confront the behavior or the belief. You do not want to confront the person themselves. And the final thing is that, admittedly, from the outside looking in, patients with a psychological disorder seem irrational. But everybody acts logically within their own framework. So if you can understand what they're thinking, what their concerns are, where they're coming from, they act logically within that. And you can use that to help them. Because again, remember, one, they often want help. Two, two is that you can then take that fact that they want help and that they are acting in ways that seem logical and sensible to them and point out where the inconsistencies are. This isn't really your wheelhouse. You're not here to treat mental illness. But a lot of people with mental illness do struggle with healthy living, like eating regularly, sleeping, and you can be a part of that, help them coach with that. There are always trade-offs in this sort of thing, as there is with every medical procedure. Treatment risk, as I said earlier, anything that alters your mental status in some way can change your eating habits. Drugs may induce cachexia, especially with older people. And there's evidence that medication may be positively associated with development of diabetes and the increase of falls with fractures. So not necessarily an increase of numbers of falls, but an increase of numbers of falls that lead to fractures. Why? We don't know. But that does seem to be, at least there is some evidence that associates that. Other interventions. There's cognitive or rational behavior therapy, which is CBT or RBT. You may see that in there. Some conditions can be controlled with CBT or RBT, especially anxiety disorders. People can benefit from those when you remind them that what they're doing is not logical, is not consistent with reality. This often is with medication as well. There is a higher recidivism rate in geriatrics with CBT and RBT than the general population. Personal theory here is that, people that are older right now came from generations in which the idea of discussing mental health openly, as people do today, it just wasn't done. You didn't discuss it and you just soldiered through, or people that were really, really bad were like shucked off to an institution and kind of we don't talk about them. So I wonder if that's it, if they're just not comfortable opening up enough that it can be beneficial. I don't know. That's just me spitballing. As far as MNT for people with mental disorders, the best one is diet liberalization. Honestly, the best one for almost everything is diet liberalization first. And go back to Owen's triage dictum on this, would be my recommendation. Maybe somebody has some kidney dysfunction, but they're also not eating. And you have to think at the time, am I more worried about their kidneys, or am I more worried about the fact that they're not eating at all? And generally, I would argue, the Academy places a premium on actually just eating food. Is their intake adequate? So liberalizing their diet, maybe it won't help their appetite, but maybe at least if the food is appealing and smells good, tastes good, maybe they'll eat simply because for the pleasure of eating. Another thing you can do is nutritional supplements. I'm not a huge fan of those, but they are effective in what they're designed to do, especially for somebody that has an anxiety disorder or maybe a psychotic disorder in which they're concerned about something. They're paranoid about the food. Again, we'll go back to that. They think it's poisoned and they won't eat. You can bring in a sealed bottle of something like Ensure and then crack the seal in front of them, or let them do it. And like, look, nobody else has opened this. Nobody else has been in this. It's safe for you to drink. Those are suggestions for people with psychiatric disorders. Here's some more reading for you if you'd like it. And guys, that is psychiatric disorders. I will catch you again when we discuss dementia. Have a good one.